It's all in your head. You don't look sick. Your tests are normal. It's probably anxiety. There's nothing wrong with you. Have you heard these words from physicians, family, and friends? If you're someone who has been struggling and swirling through the revolving door of healthcare to find answers about your health, or if you know someone who is going through this experience, then this podcast is for you. Welcome to the Desperate for a Diagnosis podcast with Laura Nozicka, a show dedicated to exploring the challenges of living with undiagnosed or rare medical conditions. This podcast explores both sides of the bedside. We will be speaking with patients who have had challenges with finding a diagnosis, along with experts in the field. I'm your host, Laura Nozicka. Please note I am not a medical professional, nor am I affiliated with any healthcare, pharmaceutical, or device company. I am an entrepreneur, and I am an independent market researcher focused on helping healthcare organizations better understand the patient perspective. The podcast is not meant to offer medical advice, but to merely share the stories and perspectives of podcast guests. Hello and welcome to the Desperate for a Diagnosis podcast. I am your host, Laura Nozicka, and I'd like to welcome everyone back to the show. And I am really excited to be talking to this lovely, brilliant lady that we've got on the show today. And we're going to be talking about migraines. And why am I excited about talking about migraines? Because I have had my share. And I don't know about you all out there, but I always have a lot of questions about migraines and why they happen and why vomiting helps relieve migraine pain. I don't know, it works for me. But all these things that we're going to learn about today, as well as remedies and medications and maybe some natural things we could do. I don't know. We're just going to go along with the conversation with our guest today. So let me introduce her so you can all get to know a little bit about her. We are here today with Dr. Lee Peterlin, and she is a distinguished clinical neuroscientist with extensive experience in NIH, foundational, and pharmaceutical funded research. Having contributed nearly 100 articles to the scientific literature on migraine and headache, Dr. Peterlin has made significant strides in the field. She completed her neurology residency at Penn State Milton S. Hershey Medical Center and pursued a headache fellowship at Dartmouth. For almost a decade, Dr. Peterlin served as the director of headache research at Johns Hopkins, focusing on migraine, biomarkers, and comorbidities. Currently, she is the founder and director of the Pennsylvania Headache Center in Camp Hill, Pennsylvania, and serves as an adjunct professor at Penn State Milton S. Hershey Medical Center. Dr. Peterlin, you have no dull and boring moments.
Hi, Laura. Thank you so much for having me on. It's a pleasure to be here and an honor to be on your podcast.
Thank you so much. But seriously, I'm honored that you could make the time with all that you have going on. That's incredible.
Well, I think it speaks to what an amazing job you're doing and the need for migraine education. So if we can do good by helping dispel a few myths and maybe provide a little bit of hope and some encouragement to anyone out there who, like yourself, has been dealing with migraine, it's really not an uncommon disorder to affect women. So it's great to be a part of this program, and hopefully we can talk about some of those.
Yeah. And you're doing so much amazing research. And I know we talked a lot in our pre-chat, not only about migraines, but we talked about all kinds of stuff, which was cool. But we'll try to keep focused on migraine as best as possible here. But I'd like to kick it off, Doctor, with just talking about the differences between kind of your everyday headache versus migraines. We hear the term cluster headaches and maybe other type of head pain. Can you just kind of help us delineate between what it all means and what it is?
Geez, what a great question, Laura. And thank you, because I think it's one that a lot of patients and a lot of people in the general community share as a question. And one of the reasons there is that question is in the field of headache right now, there's not an active or working biomarkers. So if you go to the hospital and you're going to have chest pain and you're worried that you are having a heart attack, you can walk into the ER, have blood work done, an EKG done, and they would be like, yes, you had a heart attack. No, you didn't have a heart attack. It's not like that yet with headache diagnoses. And it is a diagnosis that is largely based on clinical symptoms. And so a couple of things need to happen. The patient needs to be aware that having that headache is not normal, that it's not just what everybody has. And then the clinician has to be aware of what are the diagnoses, what are the options, and is this serious? And so one of the first things that as a neurologist you do is you want to make sure that somebody is not having what we call a secondary headache, even if it's a secondary migraine. So there's primary and secondary. Primary headache disorders, including migraine, cluster, tension type, there's, believe it or not, over 200 different headache diagnoses in the Headache Bible, the International Classification for Headache Disorders. But the very first step is you may be presenting with symptoms that we would call a migraine. That's the dress the headache is wearing, right? We want to find out if it's primary or secondary. A primary migraine means there is not an underlying other cause, right? There's not a secondary cause. It's a genetically inherited disorder that the patient has that presents as pain. If you have a secondary migraine, secondary tension type headache, secondary cluster headache, it could be, yes, an aneurysm, a bleed, a tumor, a dissection, trauma, infection, right? And that's why when somebody says, okay, we think you have migraine, we want to make sure it's primary versus secondary, the first time or the worst headache of your life or a change in pattern, those should initiate a workup from your doctor to make sure that what we're dealing with is primary versus secondary. I think that's most important. And that is true for all headaches. You want to rule out primary versus secondary. Is that clear? Does that make sense to you, Laura?
It's clear for me. The one question I did have, and maybe you can help with defining what it means, and we'll talk more about your research, but you mentioned that there's no biomarker. So can you explain a little bit about what a biomarker is?
Right. So it's just a fancy term for a test that we can use to, with high probability, identify a condition or absence of a condition, right? So there's positive prediction or negative predictive ability of different tests. And once you hit a high sensitivity of accurately predicting that, yes, this is a heart attack and it actually is a heart attack, then you can use it to identify people. So there's not currently a blood test or a scan of any kind that can diagnose migraine. Right now, it is based on clinical symptomatology. And in fact, we use the International Classification of Headache Disorders criteria for migraine. And that criteria simply says, hey, untreated, it's a headache that lasts 4 to 72 hours when untreated or unsuccessfully treated. Then when I talk with my residents, I'll say, in order to make the diagnosis of migraine, and for that matter, tension type headache, first, you map the pain, UMAP. It's just an easy way to remember it. So first, you map the pain. You need 2 out of these 4, right? So if you have 2 out of the 4 of these criteria, you need to know what the criteria are. And for migraine, the first criteria would be, is it unilateral at its worst? Is it moderate to severe? Is it aggravated by routine activity? And I would say that's the one most people probably don't know or forget to ask, in particular in regards to clinician. And then is it pounding or throbbing? Now, very clearly, I said you need how many of these? 2, right? You only need 2 out of the 4 of the UMAPIC criteria. Unilateral, moderate to severe at its worst, aggravated by routine activity, pounding or throbbing. So, can you have migraine that is bilateral? Well, yes, because you only need 2 out of these 4, right? And there's 3 other choices. If it was moderate to severe, if you prefer to lie down, not that you necessarily do, but that you'd rather that than go running down the hall or doing any kind of activity, then that would be sufficient because you only need 2. Also, migraine doesn't have to be pounding, right? Because there's still 3 other choices. So I think the classical picture, and for a good reason, is a unilateral headache that's moderate to severe, pounding, right? And that is part of the picture. But even if you had a headache that was mild, but it was unilateral and aggravated by routine activity such that you prefer to lie down, we'd still classify that as migraine. Then the next set of criteria is that you need to have one out of the two of what we call the migraine associated symptoms. And that's nausea and or vomiting, or light and sound sensitivity. We call that photo and phonophobia. It's the fancy word for light and sound sensitivity. So if you have 2 out of the 4 of the UMAPA criteria and 1 out of the 2 of the migraine-associated symptoms, that's definitive migraine according to the ICHD-3, the International Classification of Headache Disorders. Now, here's the tricky part. As a neurologist and headache specialist, there are times when I turn to a patient, I have to say, I believe you have probable migraine. And they're like, great, she's only probably sure. But that's actually the diagnosis you give when you're missing one, you're not fulfilling one of these 2 big major sets. So if you had a unilateral headache that was moderate to severe, but you did not have any nausea, no vomiting, no light or sound sensitivity, for example, that would be probable migraine. Now, your next question is, okay, well, what's tension type headache? Well, if you know the migraine criteria, you map it plus the migraine associated symptoms. Tension type headache is not migraine, with the exception of the time is a little bit different. It can last 30 minutes to days. And then it is not unilateral. It's not moderate to severe. It's not aggravated by activity. It's not pounding or throbbing. It doesn't have nausea, and it doesn't have more than one of light or sound sensitivity. So if you learn the UMAPA criteria, the migraine-associated symptoms, you can learn the diagnosis for migraine. And I think that's important. So we as headache specialists and as clinicians, we haven't fully been able to educate as many clinicians and the public as probably is warranted. There's just over 700 headache specialists in our entire country. We still have some states that don't even have one headache specialist. Now, I'm in the state of Pennsylvania, which we actually have more than the average person, but even in my state or my city, there's really only 3 headache specialists who are certified in headache medicine. You're in Chicago, so you're with the Diamond Headache Clinic nearby, so you're very fortunate that you have people whose lives have been dedicated to headache. And there are people when they have severe migraine or migraine that's not responsive to what the first line agents are tried, that you probably need to consider a headache specialist.
Yeah. Doctor, what would you say the difference is between being a dedicated headache specialist versus a neurologist, more general neurologist, let's say?
Yeah. So first of all, I am a neurologist. I'm a board certified neurologist who then went on and did a super specialty and was certified in headache medicine. So as you know, so my mentor, Tom Ward at Dartmouth, used to joke around that migraine was the Rodney Dangerfield of neurology. So we're neurologists. I did a neurology residency.
And we might want to point out to maybe the younger generation.
I'm not like that.
Sorry, doctor, but the folks was a comedic actor, very kind of slapstick guy who was known for his line in the movies where he says, what did he say? I get no respect.
No respect.
I get no respect. So migraine is like the redheaded stepchild, can't get no respect.
It was. Okay. So radically things have changed. So just to kind of put this in perspective, I did my headache fellowship back in 2004. And at that time, there wasn't a headache certificate through the United Council for Neurological Subspecialties. Now there is. You cannot become a headache specialist that's certified unless you take the United Council for Neurological Subspecialty track to be certified. But there are plenty of really talented and good headache specialists who were family practice or internal medicine prior to the development of this specialty certification. And there are many people who are advocating for family practitioners to have a pathway to be able to learn it as well, too. So I don't think you have to be a neurologist. I happen to be a neurologist, but you should have additional training, just like any other fellowship. And I do, and I did pass it, and that is the requirement now. But back in day, you have to keep in mind that a lot of neurological disorders that we don't understand, at one point we put in another category. So epilepsy back decades ago, you were possessed, right?
Yeah.
Um, with migraine, you were neurotic, right? And then all of a sudden we start to learn about the pathways that are activated. Then there are drugs that can actually manage it. And now people believe in it when they see the drastic change with somebody going from being absolutely in intense pain, throwing up, not able to function, to being able to participate in life within 30 minutes to 2 hours. And if you look at the World Health Organization's global burden of disease, and let's just look at neurological conditions. The number of years lived with disability, the greatest neurological condition is migraine. It dwarfs Parkinson's, ALS, stroke, epilepsy in terms of years lived with disability. In fact, it's more disabling than rheumatoid arthritis, angina, and diabetes combined.
Wow.
So now, obviously, we're talking about moderate to severe migraine in those cases. And I don't think anybody would choose to say, have dementia over migraine, which is considered as disabling when migraine is severe by the World Health Organization's global burden of disease study. But the point is, we didn't have a lot of good options. Now we have a lot of good options available to us. So migraine is a largely disabling disorder when it's severe or undertreated or unrecognized. And as you were alluding to, migraine is much more common in women than men. When we estimate in general population studies, 18 to 20% of women have migraine versus about 6.5, 7 to 10% of all men have migraine. In the United States alone, 39 to 40 million people have migraine. And when you look at it as 2 to 3 times more women as men of reproductive age have migraine, you get to see that it's a pretty significant problem. But I am the advocate for not forgetting men. When you talk about 7 to 10% of men having migraine, that's actually a huge number. Okay, so when we talk about 20%, it dwarfs the number of men. So the perception is that it's predominantly women. But when you look at epilepsy rates, it's definitely less than 2% for the entire population of the U.S., closer to 1%. So the prevalence of migraine is great in both men and women, but it really is substantially greater in women. If you're talking about 20% of all women of reproductive age having migraine, that is the time when we're most productive and wanting to be doing things. And yet the disability from migraine can be quite profound. You or I, we wouldn't have a job if we missed important meetings or work one day a week, every week, and that's considered low frequency. You're not necessarily going to get the same number of clients or have people searching you out if you miss one day a week every week and are unreliable. And that's what's happening to a lot of women and men who had migraine and it was unrecognized, suffering with it. You learn how to function with the mild ones, and those aren't migraine, but yet they're just mild. So the perception actually should be that migraineurs are tough cookies. My patients are tough cookies. They're actually not wimps. You know that old picture of a neurotic and a wimp? Most migraineurs, they are ignoring these things that other people would be floored by.
Well, and your patients also, we talked a little bit about this in our pre-chat. How long is it taking for patients to get to the right professional, to get the right treatment, all the visits, etc.? How many visits does it look at?
Yeah, the epidemiological studies have actually looked at this in several different ways, and anywhere from 3 to 14 different doctors have evaluated patients before they actually get help. And there's other studies that can show that by the time they get the right diagnosis, by the time they're offered a treatment, it gets even lower. And so patients are seeing an extensive number between the primary care, general neurologist, and then multiple neurologists. Yeah. So on average, anybody walking into my office as a headache specialist has probably seen at least 3 to 5 other doctors, if not more. And that's not unusual for a headache specialist. So I think the key is, one, being a self-advocate as a patient. Your headaches are significant, and there are options. I think a lot of people still think there's not a lot that we can do, but there's so much that we can do now, and there are so many things. I do have a funny story on that, and I was doing one of my first biomarker studies, and it was a blood biomarker study. And one of my good friends who was down the hall from me, she was a PhD researcher who studied vulvodynia. So, i.e., not a dumb woman, brilliant woman, right? She herself was a basic scientist studying vulvodynia. And she volunteered to be a control for one of my studies, filled out my form. And I was like, right, be a control? Great. And she was so used to ignoring everything because everybody in her family had them, and that's just what women got, right?
Mhm.
And so I think one is recognizing that if you're having significant impact on work, social life in any way, you may want to consider if you have migraine and that if there's something more that can be done other than just everybody in our family has them, we suffer with it.
Yeah. I was thinking about as you were going through your the UMAP criteria, I was reviewing all of those symptoms and thinking about the times that I've had migraine. And I remember at the time, and I want to talk about triggers versus causes and those kinds of things. But there was a time when I was in New York on business and I'd never been there before. And I'd been up early and I met a friend for dinner, had a glass of wine, went to bed, had to get up early, had to be at my client location at 7:30 in the morning, again, schlepping all my stuff because I was leaving that night when I was done. So walking several blocks through Midtown, not really knowing where I'm going necessarily.
No stress there.
No stress. And then I was doing, so as you know, I do market research for a living, and I was interviewing 6 physicians individually that day and had clients watching me from behind the glass. And then I get to the airport finally for a, I don't know, 8 o'clock flight, and the flight's delayed. And so now I'm waiting for when the next flight's going to come. I think I got home closer to midnight, and I was having sinus problems too. The migraine kicked in so badly, and of course, the plane dropped us off at a terminal that was, I don't live that far from O'Hare, but I swear the terminal was like halfway home for me. But that was so far, in the airport. And so I had all this walking to do to get back to my car. I had to find a worker at the airport to find me a wheelchair to wheel me to my car in the parking lot because I couldn't walk. I couldn't function. It was awful. So,
Exactly,
so
Laura.
thinking through causes, triggers, and we talked a little bit about the differences and some of those other components. So walk us through triggers versus causes. And I know you mentioned some genetics as well. So it's very multifactorial in terms of why we get migraines.
So before we get into that, how did you do on the UMAPA criteria? So did you have 2 or did you have 4 out of 4?
Let's see.
No. So when we talk about your worst headaches, Laura,
Yeah.
where's your headache usually located when you have your more severe headaches? Is it on the left side, the right side, the whole head? Does it change?
I would say it's one side. It's unilateral most of the time. It does switch. I'd say
And
mostly the left. It was throbbing. I couldn't function to just walk. And what was the other criteria?
Well, it was moderate to severe. It
Moderate
was
to-
aggravated by routine activity, and it was pounding.
Yep.
So what I say to my patients who are like you're an overachiever. You only needed 2 out of the 4, and you got all 4. This is what happens to overachievers. And then maybe you had some light and sound sensitivity, I'm going to imagine, because you need a wheelchair. And then maybe
nausea. Yeah.
So you definitely fulfilled the UMAPID and the migraine associated symptoms and more with gusto. Let's just put it that way. So let's back up just for a second. So what is migraine? So if you talk to a headache specialist or a neurologist, we're going to say migraine is largely a genetically inherited disorder of neuronal hyperexcitability or of the trigeminal pain pathways. You want to make it really simple. Migraine is largely a genetic disorder that is associated with abnormalities in the trigeminal pain pathway. The trigeminal nerve is what does pain to the head. And if you tie in the cervical nerves you'll cover the whole front and back of the head. So
So doctor, just to clarify for everybody, the trigeminal nerve is where and what is it connected to?
So the trigeminal nerve is our fifth cranial nerve, and it is largely responsible for feeling pain in the pain sensing structures in the head.
Okay.
So the proximal great vessels, the dura, your face. So when we tend to do something like this for a V1. So there are three branches of the trigeminal nerve. Predominantly the first and second branch are in migraine, but it can spread to three. And then that nerve will go into the brainstem nucleus called the trigeminal cervical complex. So the trigeminal nerve and the upper cervical nerves is what innervate the pain sensing structures of your head and upper neck.
So yeah, so cervical meaning again, like you said, upper neck.
Correct.
Yeah.
Yep.
Well, it's interesting that you say genetic because I don't think most people think about migraine as being genetic.
Yeah, well, primary migraine, right? When we're talking about primary migraine, about 40 to 60% of migraine can be the risk of migraine can be related to the variability in genetics. There are multiple twin and family studies, epidemiological studies that have been done looking at the risk of migraine, which also support this, as well as we have 3 identified genes for different variants of familial hemiplegic migraine. That's a specific kind of migraine with aura. So we have we have genes identified, twin studies, and family studies, all of which support that migraine is largely genetic, and about 40 to 60% of that variability is related to the gene. So not entirely, there's other factors, but a good portion of it is due to the variation, the variation in migraine risk is due to genetics. So let's say if I'm seeing a patient, if they have a first degree relative who has migraine, they have a 1.5 to 3 times greater risk of having migraine themselves. Children of migraineurs also will tend to pass it on to their children. And there is some anticipation that occurs with migraine so that the children may get it sooner than the parent. And it doesn't necessarily mean they have to get it as bad as the parent, or because grandma's weren't as bad that yours won't be as bad. So you could have the severe migraine, but grandma didn't and your children don't. So there's a lot of things that do change so that some people don't recognize it. Sometimes, as women go through menopause, the risk of migraine goes down, and then you tend to forget that you had that pain. And so some moms and grandmothers then don't share that they had migraine with their kids. And so you don't really know. In my family, so my mother had migraines, I had migraines, my sister had migraines, my nephew started at the age of 7.
Wow.
And many times children will be told, oh, they're just imitating mommy, and that's not necessarily true, right? So you have to remember that, so migraine can occur at a wide variety of age. It is most common, or the prevalence is greatest, between about the age of 18 to 55, but it's 3 times greater in women between the ages of 18 to 55. Girls tend to start and have their first migraine around 10 to 15, boys around 5 to 10. But during reproductive years, 18 to about 55, it's about 3 times greater in women. So genes plays a large role in a lot of different medical conditions and a lot of different things that we have. And I will tell my patients, hey, sometimes you get good things from your parents, like your beautiful brown or hazel eyes, as in your case, and sometimes you get the propensity to have migraine, right? And there's lots of things that we can do to help that, and let's see if we can't get that going in the right direction. So if it is primary, it means that you're going to have neurons that are more easy to excite along the pain pathways. You will be more susceptible to certain triggers, but everybody has a different potential threshold for where their neurons were going to be firing off the pain pathways. And the more triggers you're exposed to, the more likely that it'll be easier to activate you.
Let's talk about that because you hear things from migraine folks where they say, well, I can't have red wine, I can't have cheese, I can't have chocolate. You hear about a lot of those triggers. So where do those fall into play with migraine?
So very good point. If you already are easier to excite than someone who gets migraine, it may just be getting on that plane and not getting sleep, let alone having red wine. So keep in mind that red wine has the highest risk of having a migraine. White wine is slightly less, but it's still that risk. And beer may have a slightly lower risk of headache the next day, and clear alcohol probably doesn't have as much risk. But you really like red wines, right, Laura? So that might be a problem.
Well, the problem, doctor, is that I don't discriminate. I like a good Sauvignon Blanc. I like a rosé. Give me a margarita or a mojito. I'm in. Maybe I need to have a different professional to address my preferences in libations.
There we go. Right? So, yes, for migraineurs, no, we don't want dehydration, right? So you want to keep your fluids up when you're drinking. And if you can, and it's not a special case, avoid red wines. But if you're in a vulnerable period, you definitely want to avoid it. If you're not in a vulnerable period, sometimes it's worth it.
That's awesome, doctor. Yeah, we'll have to remember that. And so when y'all are looking at the wine list,
There should be a little migraine indicator, like how great is your risk next to the wine, right?
I love that.
On the other side, it's migraine risk.
I love that. Yeah, like in the restaurants, they put like GF for good food, you know?
Yeah.
That too. I like that. I think that's the next big thing for migraine sufferers. But then again, if you don't drink it all, you save a couple bucks and save a headache. So there you go.
That's right. But at least you could have a beer, save some money, don't drink, especially if you're in a vulnerable period. The epidemiological data does support that red wine is a trigger. Not so much cheese, but most headache specialists that you talk to, we do believe it. It's aged cheeses, may be a trigger. Data's not as strong as red wine or for things like MSG or nitrites or nitrates. So processed meats often have nitrates and nitrates in them, right? So if you're listening to Laura's podcast, this would be something for you to look at when you go to the grocery store. Any kind of processed meat, make sure it says no nitrates or nitrates other than what's in celery, right? So you don't want any additional nitrates or nitrates. So those are true migraine triggers. But the epidemiological data actually suggests that chocolate is not a trigger. But that doesn't mean I don't believe my patient when they say I eat chocolate and then I get a headache 8 hours later, 6 hours later. I know that. What may be happening is that there are different phases that can happen with migraine. So migraine it's not just about pain.
Are you going to draw for us again, doctor? I
have to.
love it. I love your schematics. So let's bring it on. What do you got?
Okay. So let's start with, what are the 4 phases of migraine? So there's something that we call a prodrome. You can see this.
Yeah.
An aura, the pain, which is the headache, and then a postdrome. These are the 4 phases that can happen with any migraine, right?
No, I call the post the migraine hangover is what I call it.
Right. Exactly.
Yeah. Like
So
a
the
hangover.
prodrome and postdrome are what most patients call the hangover. And this is when the brain called the hypothalamus is activated. The hypothalamus can trigger cravings. The hypothalamus can trigger irritability, mood changes, sleep changes, yawning, things like this. So the prodrome occurs hours to day. The postdrome occurs hours to days after the actual head pain component. So if you talk about that, this could be 12 to 24 hours, then about 10 to 15% of people will have an aura. So the majority of people do not have an aura, right? That's good.
How do you describe that, an aura?
Aura are neurological symptoms is not pain. So any of the aura symptoms are things like visual changes. That's the most common. Sensory changes is the second most common. Symptoms that relate to the brainstem, third most common. And then even hemiplegic, one that can much mimic a stroke.
Yeah.
And the risk of stroke is mildly increased in those with migraine without aura and definitely increased in those with migraine with aura. But it's a risk factor. I just also want to stress this, like if somebody says to you, you have elevated cholesterol, your mom has elevated cholesterol, you're not freaking out, Laura, that your mom's dying because she has elevated cholesterol, but you want to manage that, right? So that she doesn't have a heart attack or stroke. Well, when you have aura, you have a higher risk of having a stroke. You do want to pay attention, right? And minimize your risks where you can. And those with migraine with aura, particularly maybe those with migraine without, may have a mild increased risk of stroke. Okay, so you can have a prodrome, which is again the mood changes, sleep changes, cravings, yawning, things like that can happen in the prodrome. The aura symptoms, which are the neurological symptoms that are not pain, and then the headache can occur, and the headache lasts 4 to 72 hours, and then you can have the postdrome, which again is changes in level of consciousness, fatigue, or hyperness. Imagine me more hyper. I actually do get more hyper before my. So other people will get profound fatigue. So and I've had that too, where you get just like sleep attacks, right? But this prodrome is probably where some cravings, like the craving for chocolate, happens, and that's the start. That's actually the start of the migraine. So when patients say, "Yes, I eat chocolate and I know I get a headache," I believe you, but I think it's not a trigger. I think it's the start.
No. Interesting. Okay. Yeah.
So, I mean, this is classic. You don't have to have all 4 of these. You can actually, you don't even have to have the migraine pain to have a migraine, right? You could just have the prodrome and the aura, believe it or not.
Wow.
And as we get older, we tend to lose some of that head pain component. So after the age of 55, the risk is higher for you just having the aura and not the head pain, actually.
Is that hormone related then, doctor?
Well, so hormone is one of those triggers, right? So you mentioned triggers, and yes, we believe red wine and nitrates, MSG are triggers. Aged cheeses may be, and if you tell me that whenever you eat coconut, it triggers a headache, okay, great, but don't eat that. But there are some bigger triggers like fasting. Skipping a meal is a bigger trigger for headaches, and that means a trigger is just something that makes you more susceptible to activating that migraine pain pathway.
Yeah, I get that because when I get hungry, I at least I get a headache and I try to eat so I can cut it off at the pass because I know I could get to the point of no return and I'm in a full blown migraine. So I make sure I eat. Yeah.
Perfect. That's what I would say to my patients. You've got to be aware of what your triggers are. Be cognizant of the fact that when you skip a meal, that's a big trigger for you. And then you might be able to handle not getting quite as much sleep as you need before an interview, right?
Right.
If you made sure that you had that you ate, that you kept your stress as minimal as you could. So when you talk about triggers, things that make it more likely for you to have a migraine, if you have the propensity to migraine, the number one for both men and women is stress. I mean, and in the headache you just described, you literally had like all of them. So stress would be number one. Fasting is number 2 for men. Menses is number 2 for women.
Okay.
So it is not estrogen that causes or triggers migraine because men get migraine, right? Having your period makes you more vulnerable because you have a big swing in your estrogen levels. So right before you start to have your period, you ovulate, you get a surge of estrogen, and then estrogen levels plummet, right? That's why that plummet of estrogen is what triggers you to have menstruation. And that 2 days before menstruation to about 3 days after is when women are at highest risk of having a migraine, but they're also at higher risk for having all pains. There's a big change and there's an increase in pro-inflammatory proteins that are made in the body, a decrease in the neurotransmitters that inhibit pain. So that's a vulnerable period for people who have migraine. And for women, the number 1 is stress. Number 2 is your period. Number 3 is fasting. And then whether sleep, and it's sleeping too much or too little can be a trigger. And don't forget, weather changes like barometric pressure changes, and you described that you were stressed, you got up early, you had a glass of wine. I don't know what time you ate that night, but I bet you it wasn't at your regular time.
Yeah, correct.
And then you had pretty significant stress, even if it was happy, good stress. You had 6 interviews to do and you wanted it to be good, even if this is something that you can do in your sleep. It was something that you were excited about and a little bit of stress. And then you had a sinus infection on top of it, right? So it is more common for migraine to cause sinus-like symptoms, but when you have an active sinus infection, it can actually trigger a migraine too. So triggers will activate a migraine in people who are already susceptible. They don't cause that. Like if you one of your male friends was with you on the plane and he didn't get sleep as well and he had a glass of red wine, he didn't get a headache, right? And so you have to keep in mind that it just makes you more vulnerable. And so, but perhaps on a day when, all your interviews are done, it's now the weekend, it's 3 days later, you caught up on your sleep, maybe you could have a glass of wine, right? And so it's about knowing what are potential triggers for you. And then, is it having exposure to multiple triggers or is it just one, right? So, my dad was he's a retired meteorologist. And I used to tease him, hey, I can predict the weather better than you, right? And so every time before it would rain, I would get a mild migraine. And so it's just about learning yourself. And okay, if you know the weather is going to change, okay, I really need to make sure that I don't skip a meal or change my eating patterns, that I try to limit my stress where I can, and then you might be able to handle it. And definitely, if you're if you need treatment, then we should be able to get you to the point where those aren't triggering you.
Yeah. Yeah. So in this continuum of management, you started talking about knowing yourself, knowing these potential triggers and how to balance all of that. Doctor, tell us what's going on in the realm of treatment from a pharmacological standpoint, and maybe what some of the options are from a non-drug standpoint that have worked for patients or has some research behind it.
Great. So there is so much that can be done. I just think it's really important, besides keeping track of your headaches, identifying your triggers where they are, there is substantial data about different ways that you can manage it at different levels. So when you have, say, episodic migraine, which is less than 15 headache days per month, you want to put that fire out as fast as possible. And that is done with things that we call acute abortives. Acute abortives put out this migraine you're having now. Doesn't stop headaches in the future. That's prevention, right? So
What's the term?
acute abortive agents are things like and non-steroidal anti-inflammatories like naproxen sodium, right? Like triptans. So you sumatriptan, Imitrex, you've heard that.
Yep.
Right? So acute abortives are to put the fire out now. So if you picture having a migraine and your brain is just firing off and it's on fire and you want to put that out, you want to douse it, right? But we just have these tools. We have non-steroidal anti-inflammatories like Elite, but even things like Tylenol have data behind them. You just want to make sure you're using the right dose, especially depending on what level you are, mild, moderate, or severe.
Yep.
And different pathways are involved. And so we have different drugs that target different pathways. So there are some drugs that target things called prostaglandins, which are involved in the inflammation. There are things called triptans, which target serotonin. And more recently, in the past 5 years, we have drugs that target a protein called calcitonin gene-related peptide. And there are drugs that are used for acute abortive agents that target this protein CGRP, and there are preventatives. So there are several different pathways that overlap and are activated in pain, and specifically in migraine. And the non-steroidal anti-inflammatories are non-specific to migraine, right? They treat pain of multiple different ways. The triptans and the CGRP receptor antagonists are actually specific to migraine therapy, acute abortive therapy. You want to use those as soon as possible. You just don't want to run the risk of overusing it, even over the counters, because migraine brain can get used to, it's a double-edged sword. If you use acute abortives more than 3 days a week, it can actually prevent you from responding as well to any treatment or even that treatment. That's not so true with the drugs that target CGRP for acute abortive therapy. It hasn't been proven that it happens with that. But the point is, when you have a fire, if it is episodic migraine, you want to put it out. There are also things that we can do that I would call rescue therapy. It's what's used if the acute abortive didn't work well enough, or if you already hit your 3 days per week. It's just additional things that you take as needed. The prevention is really the key, especially when you start having 4 or more headache days per month, or if you have any kind of disability or limitation that's regularly associated with your migraine, you would want to pursue prevention. And prevention can be behavioral, It can be pharmacological and it can be non-pharmacological. And prevention just means that it's something you do regularly on a scheduled pattern. It doesn't matter where your head is at that moment. You are taking it so that next month, the month after that, you have less or half of the number of headache days as you did the month before. Or even nowadays, my goal is always to get patients less than 4 headache days per month. For all my patients, even the ones who come in with a headache every day, right? Who they're like, I've had a headache every day, or I only get 1 or 2 headache-free days a month. My goal is always working towards that. Believe it or not, you can do things like exercise. There's some data, not strong, but data behind acupuncture and yoga. The best data is behind cognitive behavioral therapy and biofeedback when it comes to the behavioral. And people who do both a behavioral and a pharmacological will be better than people who do just one or the other.
Yeah. So it really is a multifactorial management plan.
It can be many people. There are some people who are easy and it doesn't require quite so much. The data's pretty good for exercise. You doing aerobic exercise for 3 days a week for at least 30-minute session. It's not even as much as what the American Heart Association recommends for cardiovascular health. So if you could just get 3 days in for 3 minutes, that can be considered preventative. And then when we talk about preventatives, there are the older drugs that we used to use, which are anti-epileptics, antihypertensives, antidepressants, and then there are migraine-specific preventatives that target that protein called CGRP. Those drugs now are fantastic in that you've got options in how you take them. You can take one orally daily, you can take one once a month as an injection, and there's even an IV that you can take once every 3 months for 30 minutes. Done. And I tell my patients, I have to go to get my hair done for 3 hours every next week. So you can go for 30 minutes every 3 months, and it just depends on how bad you are. Well, what is and how urgently you want to get better, what patients tend to choose. And obviously, migraine can be pretty disruptive of work life and your family life undertreated.
Yeah.
And so one thing that I didn't mention is, yes, there are supplements there are about 6 supplements that have decent data behind them. One that I wouldn't use because there were deaths in Europe from hepatotoxicity. I don't know if you want me to say that, but that would be the ones I would recommend because they have some randomized double-blind studies behind them or data that is highly suggestive. Riboflavin. Riboflavin is vitamin B2. It's not B6 or 12. I tell my patients 1, 2, buckle my shoe so that they remember.
Oh, that's a great way to remember that.
Turns your urine yellow, but the data suggests that it can decrease the frequency if you take it regularly for longer than a month.
Is there a dose that you recommend?
Yeah, well, so the 2 studies with riboflavin were 25 and 400. I ask all my patients to do the 400 as long as there's no contraindication. And then magnesium also at 400. So magnesium
Per day, right? Per day.
Okay. Yeah. So magnesium can loosen your stool. So you want to be careful there, especially if you have irritable bowel or anything. So if you have constipation, it's great. But magnesium is good for sleep. It's good with mood. It's good for the aura and some good for the headache. So magnesium is definitely always on that list. Coenzyme Q10 has pretty decent data, 300 milligrams per day. Melatonin, there are some studies that suggest melatonin 3 milligrams at night. And you have to remember melatonin is chemically very similar to serotonin. But caveat is you can't just take melatonin as needed for your sleep and it help your migraines. It does need to be every night.
Okay. Yeah. So are you suggesting these supplements kind of try one for a certain amount of time, see how it works, or is there some combination that tends to work well?
Really should have somebody kind of look at your whole picture. You don't want to just start taking everything immediately.
Right.
There are people who do and can. And I'm one of them. But yes, if you're doing this on your own, you should not do anything rapidly and just boom, start all. I would pick one, get it to a dose that you're comfortable that you can tolerate that does not exceed the limit, and do it for a good 2 months. more than 4 days per month, that you probably should be doing this with guidance.
Yeah. Yeah. I was going to say, and certainly don't attempt any of this without talking to a physician because you might be on other medications and there might be some contraindications for supplements. Doctor, another thing that I wanted to see if you wanted to talk about, you're doing some interesting research on migraines and obesity. Is that something that you want to chat about a little bit and what you're finding, or maybe any other research that you're working on?
Sure, we can touch on that. So I think it's really important that we recognize that we get clues from lots of different ways in medicine. And just because you notice that there's an association doesn't mean that it's causing migraine, or understanding that association means that's, if we figure that out, it's all over. I think it's important to recognize that medicine is constantly evolving and changing. And one, you can either have a clinician who maybe doesn't fully understand or doesn't want to work with you, or we just don't have the data. And so you have to be careful when somebody says, I don't know, to know, does that mean that the field doesn't know, or this doctor doesn't know and you need to be referred to somewhere, right? So I want to keep that in mind, that, back in the 1950s, doctors who prescribed triple antibiotic therapy were being given fines or put in jail for peptic ulcer disease. In the 1980s, we gave the Nobel Prize in Medicine to the doctor and the research scientist who determined that triple antibiotic therapy eradicated the H. pylori bug that causes peptic ulcer disease. You want to keep in mind that we're talking about science. We once thought if you didn't know how to use leeches for everything, not just wound care, that you were a quack doctor. So you have to understand but I think you want to make sure that you're doing something that's logical, that there's some data behind, and that makes sense for anything in medicine. And this is kind of like my caveat. I always wonder, what is our leech of my century, right? So there's always something. Yeah, the guy who first said do hand washing. It used to be that obstetrics gynecology, that doctors didn't wash their hands in between. The bloodier your hands were, the better of a midwife you were.
Oh my, I can't imagine that going over too well.
Well, so guess what? Hospital, this one doctor started washing his hands, and his death rate in that poor hospital was better than the big expensive ones where they didn't. And and so the guy who said wash your hands was first laughed at, right? And that's what most great discoveries, first they're laughed at.
Yeah.
They're met with indignation, and then finally they're accepted like it's fact. Like nowadays, we accept it. It's fact. You wash your hands, right?
Yeah. Yes.
So I think that's important to keep in mind. So that being said, so one of my areas of research was looking at hypothalamically mediated migraine comorbidities. The hypothalamus is a small part of the brain. It's involved in PTSD, obesity, because the hypothalamus drives the desire to eat or not eat. So satiety or not satiety. So do I need to eat, or am I full? The hypothalamus is involved in that, and in level of consciousness, or like sleep. So disorders that sleep, post-traumatic stress disorder, and obesity are things that the hypothalamus plays a role in. And in migraine, the hypothalamus is activated during that prodrome and postdrome. And so my research looked at the association between migraine and obesity, and migraine and PTSD. In terms of the association with obesity, the research is pretty darn clear now. Maybe back when I first started, it wasn't clear. But now there's over 41 epidemiological studies that have looked at the association between migraine and obesity, and people who are obese have a greater risk of having migraine. There's also bariatric surgery studies that show that morbidly obese patients who undergo bariatric surgery have a decrease in their number of monthly migraine. Initially, we thought maybe it was just associated with high frequency episodic migraine or chronic migraine, but now we know that the risk of migraine is increased in those with obesity, whether it's episodic or chronic. So both episodic and chronic, and it's probably there's a greater risk in those who have chronic migraine, or there's a greater risk for chronic migraine in those who are obese. But it's like even with depression is greatest in those with chronic migraine and greater than even those with episodic, but both episodic and chronic migraine have risk of migraine. So the bottom line is that migraine and obesity are related. The risk of migraine looks to be increased in those who have obesity, and there's a shared pathophysiological inflammatory pathway between the two. And a lot of the pro-inflammatory proteins that are activated in migraine, believe it or not, are also increased in obesity. So I began to look at some proteins that were secreted predominantly from fat cells called adipocytokines, and did some research looking at adiponectin, leptin, and resistin inside and outside an acute attack. And it looks like during an acute attack, there were changes in adiponectin that decreased and went back to the normal with successful treatment. So there's potential for drugs potentially to target one of these adipocytokines. And I also looked at things called single lipids, which are lipid cell membranes and in neurons. And we're using a panel of those. We are able to identify migraineurs versus non-migraineurs without them saying a word. In a small panel, it needs to be validated before we can say anything more about that. But it's encouraging that there is potential that we will someday be able to identify migraine just getting a blood test.
Yeah, yep. Well, like you said, all in the name of progress, despite the initial ridicule of some of these brilliant physicians of the past. And
Well, let's put it in perspective.
early adoption isn't for everybody, right? So
Correct. But I also even once it is adopted, so Lars Edmondson, Peter Goadsby were doing amazing work back in the early 1980s, looking at calcitonin gene-related peptide animal studies, really showing that there was involvement with the trigeminal pain pathway. It's what, 2024, and for 5 years we've had drugs out targeting CGRP. So they started that work. They're giants in our field. They began doing that work in the 1980s.
wow.
So just think about how many decades that means from the time that somebody goes, I think this is related, to when it comes out. So it really is true that, we each stand on the shoulder of giants to make a small step forward. And
Yeah.
it's really thrilling that we got to see the drugs that target CGRP come out right now, because it's really changed the field of headache medicine. We have drugs that were specifically designed for migraine. They have lower side effects than a lot of the other things that we ever could offer, and really are effective. So people really have some great hope who before didn't have options, or they didn't like the side effects from some of them. So, I mean, it's been a very satisfying time to be a headache doctor. Now people want to become a headache doctor. There's a need, there's a demand, clearly, right?
Sounds like it. Yeah. Yeah. And to your point about how long it took for these discoveries to get more mainstream, it just shows you too how long it takes for pharmaceuticals to be tested and get into the market. And I in a past life, I worked in patient recruitment for clinical trials, and I left that company back in 2016. So here it is 8 years later. And just, I think a year or two ago, one of the medications that I was working on for patient recruitment for a lupus compound was just approved. So it just goes to show you how long it takes for these medications to, again, get into the market, get tested, be mainstream and whatnot. But before we wrap up, doctor, I'm interested in what kind of advice you might give a patient who is that patient who has seen 3, 5, 7 plus physicians in getting the care that they need. Maybe what are some good questions for a patient to ask a headache specialist in terms of building rapport and becoming comfortable and just knowing if this is the right doctor for me? What might you recommend?
Oh, thank you for that question, Laura. So I think this may be the most helpful thing of all that we discussed for anybody out there who is looking for a doctor. So please, yeah, it is great to have a patient who does research and who is knowledgeable. I think most doctors nowadays, if they're not comfortable with you having done some research, that should not be the doctor for you, right? But there are places that are going to give you higher yield. And I would really strongly encourage anybody who wants to figure out what kind of headache they have to look at the National Headache Foundation, the American Headache Society websites. So the American Headache Society and the National Headache Foundation are wonderful advocates of places where patients can look to get education and to locate a doctor who is certified in headache medicine. So if you're, family doctor can help you with like high blood pressure or mild migraine. But if your family doctor isn't able to help you or it's not helping enough, then yeah, you're going to want to ask for a neurologist or a headache specialist who has a certificate in headache medicine. You don't want just somebody who's willing to see a headache. They should be certified in headache medicine, and you definitely want to make sure that you had the full workup. So yeah, I strongly recommend seeing a neurologist who has also additional certification in headache medicine. And that you check out the websites that are great for patients. So both the American Headache Society and the National Headache Foundation have links to some of the patient advocacy groups, which are fantastic. There are some patient advocacy groups that are absolutely wonderful. And ways that you can locate a doctor. But I would recommend not giving up. If a doctor says they can't help you or won't help you, believe them and move on.
Yeah.
And then your next step is to, Google, you want a headache specialist. You don't want just somebody willing to see headache. You want somebody who has that headache certification. Well, how long have you been practicing headache? Oh, so the headache isn't all you do? You're just willing to see headache? It depends on how bad you are, how much you need, right? So I would say, a family doctor or a general neurologist can absolutely handle mild migraine and get you started on the right pathway. But if you failed more than one drug or you're severe or you want rapid treatment, yeah, I'd be looking for a headache specialist too.
Yeah. Well, Dr. Peterlin, I think you're giving all of us hope that there's relief out there, more than probably folks even realize. So, how can listeners get a hold of you or learn more about you?
So if you're in Pennsylvania, I'm at the Pennsylvania Headache Center in Camp Hill, PA. You can Google my website. It's the Pennsylvania Headache Center. I also have a Facebook page. So hopefully I'll be putting a link to our podcast, Laura.
Yeah, I would love that. I would love that.
So maybe they can check that out, and I'd be happy to talk with them. If they give us a call at the office, that's also a way to get in touch with me.
Perfect. Well, Dr. Lee Peterlin, this has been so informative, and hope it's been informative for everyone else. I so appreciate you being here.
Thank you so much again for this opportunity, Laura. And don't hesitate to reach out to me if you need any advice or help.
Thank you. Well, I appreciate that. And this is another amazing episode with a lovely, brilliant physician, Dr. Lee Peterlin. Everyone, this is Laura Nozicka, your host of the Desperate for a Diagnosis podcast. Stay well, everyone, and keep pushing for answers.
Oh my goodness, that's a wrap on another compelling story. Thanks for listening to the Desperate for a Diagnosis podcast. If you would like more information about today's guests or to find out more about Laura, me, go to desperateforadiagnosis.com. If you enjoyed the show, please subscribe, rate, and review the podcast on Apple Podcasts, Spotify, YouTube, or wherever you get your podcasts. You can also follow show updates and healthcare news on the podcast's Facebook page. If you would like to be a guest on the show, or if you have any questions, advice, or suggestions for our guests, please email me at lauramarie@desperateforadiagnosis.com.